Very good morning to all of you. It's been a hot May, and we are out to tackle a hot topic, that too in just 60 minutes. And plus there are some other questions by echo fanatics. So we'll see what all we can cover. Our objective is have an introduction to echo assessment of diastolic function of the left ventricle, adults and pediatrics, and at the very end we will touch upon Simpson's method for systolic function assessment, TAPC, aortic measurements, and any other questions. This is my disclaimer. There's no pretense at all that this is going to be complete. Lots of incomplete information in fact, and I'll consider my goal achieved if at least or even 10% of the audience here today attempts to obtain diastolic function indices over the next few weeks at the next opportunity, or at least reads up about diastolic function assessment. The truth of the matter in pediatric cardiology actually is that we as pediatric cardiologists do structure. It's the adult cardiologists who do function, systolic, diastolic. We love our anatomy, the defects, VSDs, PDAs, DORVs, single ventricles. We love exotic diagnoses like hemitruncus and LV to aorta channel, LPA sling, crisscross heart, and so on and so forth. When it comes to function assessment, most of the time we are extremely limited. Some in DCM, definitely the dilated cardiomyopathies, the immediate post-op patients, the TET patients on follow-up for the RV side of function assessment. Keep hitting the wrong button. So for the systole part, it's pretty alright. We have a list of indices we use, very much less than the adult people, but yes, we have our list. When it comes to diastole, we pretty much draw a big blank. But we actually should be getting serious about diastology. Look at this chart over here. On the x-axis are years, and on the y are patients. This is a clinic data from somewhere in the Western world. The different color bars go over specific age populations. At the bottom of each column you see these blue denote live births with CHT, while the yellows are children with CHT. The dark yellow is 18-year-olds with CHT, and the dark blue is the adult population. So take a look here in 1990-94 column. It says the adult population is minority, and what happens in now, where we are now, adult population is the majority. What is predicted is that it's going to become even more so. So what that implies for us is that we will be having to deal with adults whether we like it or not, and adults with CHT are a whole different issue altogether. A big problem with them is also heart failure, and failure obviously means systolic and diastolic failure. So we have to know how to evaluate diastolic function. We need to know what the adult world is doing as far as diastology. Obviously in our own pediatric patients, we do want to get into diastology to try to prognosticate amongst DCM patients what the mortality, morbidity is likely to be. Also the group of LVOTOs that we have, the chemotherapy patients, where you want to pick up the earliest sign of heart failure, of heart compromised function on echo, to differentiate between restrictive and cardiomyopathy and constrictive pericarditis, and also diastolic evaluation of the RV, which we're not going to touch upon here. For us in pediatrics, we don't get cooperative patients like the adults do. The heart rate is much faster. That impacts how the waves are seen on spectral imaging, Doppler imaging. Unlike the adult guys, We don't have a single number cutoff point to remember for various things. Each age group has its own normative data. And also remember that the process of relaxation has been very well studied. Well, it is getting better, decade by decade in adults, while in pediatrics it's still unknown to a large extent. So before we begin, my first question for you all, and this is going to be an interactive session, I hope. Please ask questions. My first question is, how do we perform interrogation of the mitral valve for diastolic function assessment? Do you use a continuous wave or a pulse wave Doppler, or either is fine as long as you get a spectral Doppler tracing? Can anyone answer so that I can move on? This is easy, isn't it? So somebody says PWD, and that's perfectly right. Next, when does diastole, that's ventricular relaxation, start? You have the ECG tracing given over here. When does diastole start? Does it begin at the beginning of the P wave, at the peak of the R wave, at the beginning of the T wave, or the end of the T wave? So reflect upon this. I'm not going to demand an answer. Somebody says beginning of T, somebody says end of T. I see the answers there. So you will figure out by the end of this, in this talk, I hope. When does diastole end? When does ventricular relaxation end? Does it end when the P wave is over, or when the Q wave begins maybe, or at the peak of the R wave? Something for us to reflect upon. How is diastole reflected on the ECG? So somebody says end of P, somebody says end of R. I think we have 33% distribution each for all of the three answers. Obviously only one is correct. Next question is, what is the systolic diastolic ratio time-wise at a normal heart rate of 75? Systole diastole ratio. So is it 1:1? Is it 3:5? Is it 1:5? What are your thoughts on that? Somebody says 1:1. I'm happy people are replying. Somebody says 3:5. Somebody says 1:5. So again 33%. All right. Great. Next, true or false? Ventricular diastole is an energy consuming process. Ventricular relaxation, does it consume energy or not? Is that true or false? So we have 3 truths, 4 truths. Okay. Next, normal values of tissue Doppler imaging in children don't exist yet. A, true. B, false statement. And C, don't know, don't care. I hope there are no C's here. False. Okay, somebody says true. All right. So we have a 50-50% vote there for true and false. So back to basics. You knew it would be back to basics here, didn't you? So we are beginning with what is ventricular diastole. It's the time when ventricle relaxes. And look at this diagram over here. It begins at the end of the T wave. The T wave is what shows up for depolarization of the ventricle. At the end of the T wave is when ventricular diastole begins. Unfortunately, all of our explanations, cardiac cycles, and everything start with where P wave, begins. So ventricular diastole beginning kind of falls in the middle of the whole diagram, and where it ends is at the peak of the R wave right here. So you have to go from here right up to this side, up to where the R ends. Another way of looking at it is ventricular systole is when R wave peaks to when the T wave ends. The rest of the time it's diastole, ventricular systole and ventricular diastole. So the correct answer to question 1 was that the ventricular diastole begins at the end of the T wave. I'm not sure if everyone can see this. Okay, so this is a rigorous diagram that we've used multiple times in physiology. Going back to it now, look at this. What's easily recognizable is at the bottom, the PQRST, all right? And then look at this. This is the LV pressure, this big one. And right here, almost a straight line with a few bumps, is the left atrial pressure. We are going to move with this red line drawn at the aortic valve closure point. This coincides with where the T wave ends, and this is the beginning of ventricular diastole. Come around this way to where the peak of the R wave is, and this is where your mitral valve closes. That's where the diastole ends. We'll get into a lot of details of this as we move on. So, big valve closure, mitral valve opening marks the beginning of the rapid ventricular filling period. That's the rapid ventricular filling period. Then is a period of slow ventricular filling, that's called diastasis, and come along on this side then where the P wave is, and that's when the atrial systole happens. I keep having to move the video box, alright. So again in detail, because all of diastology is about this, this bar marks where ventricular diastole starts at the end of T wave. You've got the aortic valve closing. All right. The next line separates out the isovolumic relaxation period. So the aortic valve has closed and the mitral valve opens at the yellow bar. Between the red and yellow lines is the time when both the valves are closed, the aortic and the mitral, and the ventricular pressure is rapidly coming down. You see the rapid decline in the ventricular pressure. So the volume remains the same. It's isovolumic relaxation time. The next phase is beginning with when the mitral valve opens to when the left atrial and the left ventricular pressures come to be almost the same. This period between the yellow and the green bars is the rapid ventricular filling period. Most of the filling is done in this time. Now you've got to come around to this time, like this, around the picture. The reduced ventricular period starts after the pressures have equalized and ends at the atrial systole. So there's no line here for that. And last phase is atrial systole. At the end of atrial systole is this red bar. So consider diastole as phases of 4. First is the IVRT, isovolumic relaxation time, beginning with closure of the aortic valve and ending with opening of the mitral valve. Then is the rapid filling time. Then is the diastasis period. That's when there is no pressure difference between the left atrium and the left ventricle. This is actually, velocity over here. So you've got blood flowing across the mitral valve at some velocity in rapid ventricular filling. That velocity is very, very low, close to 0, less than 20 centimeter per second in diastasis. And then in the last phase of ventricular diastole, there is atrial systole when the velocity goes up again in the transmitral flow. Look at this. This is the pie chart. Ventricular systole at a heart rate of 75 beats per minute, giving 0.8 seconds per cardiac cycle. Ventricular systole occupies 0.3 seconds. Remaining time is ventricular diastole, so that's 0.5. So that's one way of answering that pre-test question, that if you look at ventricular systole diastole, then the ratio is 0.3 or to 0.5 or 3:5. But if you look at complete cardiac diastole, that only lasts for 0.4 seconds because you've got the atrial systole coming here for 0.1. So you have systolic diastolic ratio actually being 1:1 right over here. 0.4 here, 0.4 here. Let's move on to phase 1. Once again, the isovolumic relaxation phase. Remember, it's when the aortic valve closes and the mitral valve hasn't opened yet. The left ventricle is relaxing. There's a sudden pressure drop rapidly. LV peak systolic pressure in an adult is 120, in an infant is 80 mmHg. So that pressure has to come down to close to 0. So rapid pressure drop, and it ends when the mitral valve opens. Mitral valve opens because the LV diastolic pressure becomes lower than the left atrial pressure. A normal isovolumic relaxation time reflects that the LV is relaxing very nicely. And diastole is all about analyzing relaxation of this LV and also how it fills in the late phase of diastole. Phase 2, the rapid ventricular filling period. So when the mitral valve opens, it does so because the left atrial pressure is higher than the left ventricular pressure, and that pressure difference creates good flow. Most of the filling in fact happens in this period, exception being the fetus and the neonate. And this is what generates the E velocity of the mitral valve pulse Doppler. The E velocity. It reflects the health of rapid ventricular filling. The E velocity will shoot up, will increase in height if the left atrial pressure is high. Whether it is due to something like mitral stenosis, or in the absence of any stenosis or regurgitation of the mitral valve, if there is diastolic dysfunction severe enough to elevate the left atrial pressure, then the E wave shoots up. However, in early diastolic dysfunction, when the left atrial pressure is not high, then the pressure gradient between the left atrium and the ventricle decreases, so the peak E velocity falls. Normally E is taller than A because there's more filling happening in E versus A. So the ratio of E by A is less than 1, it's usually 0.8. In early diastolic dysfunction, the E will become less than A. Phase 3 is diastasis. Remember, when the LA and the LV pressures are the same, there's hardly any flow happening. The left atrium hasn't started contracting yet, and whenever there's tachycardia or most of our pediatric population, diastasis is very, very less. This is a PW Doppler of the mitral valve showing an E and an A wave, and in between, when there's diastasis, you actually see some flow happening. When that flow is high, when this doesn't touch the baseline, but you've got a length to it, and there are other parameters that are in agreement, then you can come to a conclusion that there is diastolic dysfunction. These are some of the things which are confusing, and many of the times in our pediatric side we see a lot of EA fusion, just a single wave. So is that what this is? Absolutely not. That fusion might be normal or is normal. What I'm talking about is something totally different. I'm talking about in the period of diastasis when you have two separate peaks, E peak and an A peak, and in between you have some flow happening denoted by some velocity of blood captured in your spectral Doppler tracing. So that denotes diastolic dysfunction. The last phase is atrial systole. That's when the atria contract and push in blood into the LV. So this part of ventricular diastole has to do with how the LV, how compliant it is. In diastolic dysfunction, relaxation is impacted first. Remember the first bit, the IVRT, and when the peak A happens on the mitral valve pulse Doppler, that's the part which is impacted first in ventricular diastolic dysfunction. So far we've gone over the 4 phases of diastole. Now diastole, is it all relaxing? It is relaxing, but doesn't mean that there's no energy being spent. Look at this diagram. This hashed portion is the isovolumic relaxation time, and when your left atrial pressure is higher than the left ventricular pressure. So that point is captured over here. This is a time when there's actually a lot of energy being spent, because it takes energy to send the calcium out of the cell for its reuptake. So anything that impacts the energy provided to the heart, whether it is ischemia or other things, is going to impact relaxation. It's actually a energy requiring process, and implies that when there is systolic dysfunction of the ventricle, there is going to be diastolic dysfunction of some degree or the other. What happens in that phase in IVRT, extending into the rapid ventricular filling, is that the ventricles untwist. You may have heard this term, the twisting and torsion, how ventricular contraction is not just about longitudinal compression, not just about radial or circumferential compression. It is also about how the ventricle twisting and torting in systole. So it's as if you are wringing a mop to get the water out of it, to get the water to move out in a particular direction. Similarly, the LV rings itself from the apex towards the base where the aorta is situated, so that blood is expelled out into the aorta. So this twisting and torsion happens because of different direction of muscle movement in apex versus the base, also the subepicardial layer of muscle versus the subendocardial. This is happening in contraction. What's happening in relaxation is that it untwists, and that, you can imagine, creates a powerful suction effect. In diastole, that suction effect extracts blood then from the left atrium into the LV. Anytime this suction effect is impacted, because it's not, the LV is not allowed to untwist properly, whether it's energy deficiency or something in the myocardium, then your diastolic parameters obviously suffer. So we have 4 phases of diastole, beginning with IVRT, isovolumic relaxation time, and ending with atrial systole. The first couple phases deal with how the LV relaxes, and the last phase is where the LV has to distend. It's already relaxing, but now it has to distend. It has to do with how stiff it is, or in other words, how compliant it is. LV relaxation requires energy. Now, echo is able to study all 4 phases of diastole. What are our tools here? Number 1 is mitral pulse W, Doppler. We do a gauge, we put a gauge across the mitral valve, and we study the velocity of blood as it rushes into the left ventricle. It's comparatively high velocity. We look at the E and A waves and the EA ratio, and also look at a couple time intervals, including the IVRT and the deceleration time. Tissue Doppler imaging is number 2 of our echo tools for assessing diastolic dysfunction. So here we are looking not at blood, we are putting that very same sample gauge on the tissue, and this tissue obviously doesn't move at the same velocity as blood does. It's very much lower. So if your peak velocity of blood as it rushes into the left ventricle in early diastole is, let's say, 70 centimeters per second, if you look at the tissue, how much it moves in that phase, it will be more like 10 centimeters per second. So it's low velocity. You need to adjust your settings to capture that. And these days, almost all machines have presets for tissue Doppler imaging, where very little adjustment has to be done. And we look at the waves which are mirrors of the mitral PWD, which is E prime and A prime waves. We also are able to look at the IVRT. Now, combining the mitral and the tissue Doppler imaging is one important index, which is the E by E prime ratio. Very, very important for diastology. Tool number 3, I allot that number to the left atrium and how its volume assessment affects us in diastolic dysfunction. Number 4 is pulmonary venous pulse Doppler. Other tools which are very essential, as essential. Number 1 is LV, systolic function. Remember what I said about diastole, the relaxation components being energy dependent, and if energy is impacted, supply of energy, and it's affecting your systolic function, it's definitely going to impact the diastolic function as well. So better you start, you know what the systolic function of the ventricle is before you get into evaluating diastolic function. The PA pressure estimate is very, very important as well, because if you realize, obviously they are connected circuits across the pulmonary capillary bed. On one end is pulmonary artery, on the other end is the pulmonary venous and the left atrium, circuit. So if your left atrial pressure is high because there is diastolic dysfunction, the pulmonary venous pressure will be high and the pulmonary arterial pressure will be high. So use that to determine if your left atrial pressure is high. Also look at the myocardium, look to see if there is hypertrophy, etc. Any clue that the myocardium is not normal will help you assess the diastolic function of the patient. So let's look at these tools in detail, beginning with mitral PWD. We begin by, we obviously use it in the apical 4-chamber view, and we put the gate at the tip of the mitral leaflet, the very tip. I have a couple more slides devoted exclusively to that. So before I move on to the next slide, let me also add that this is not reliable when there's AV block or there's sinus tachycardia or your waves are fusing. Looking at the E wave happening when, remember, your LA pressure is higher than the LV pressure, and most of the rapid filling happens in the E and less of it happens in the A. All right, so this is the most important slide, one of the most important slides of this presentation. This looks at where the gate should be for analyzing diastolic dysfunction. It has to be pulse wave Doppler, and the position has to be right here at the tip. Not here at C, not at B, not at A, not at E or F either. Now why does it matter? Because we know clearly that as the pulse gate moves into the left atrium, here these, your velocities come down. And a lot of diastology is based upon the peak velocities and the ratios. So if you're getting something which looks like this, when actually it's this, you'll have skewed up your analysis. And once you do that and it doesn't fit with the rest of the echo and how the patient is, you're going to say, oh my goodness, diastology is bad, diastology sucks. And the truth is that we didn't do a good job of getting the data. So most important, to figure out where to keep the gate. It has to be at the very tip. It doesn't have to be somewhere higher up into the LA. Garbage in, garbage out. Your analysis is only as good as your data. Don't even bother getting into EA ratio and other stuff if you haven't practiced getting good pulse wave Dopplers. Remember that our adult imaging colleagues do function all the time. Most of the time they're analyzing function of their patients. So learn from them. Make the adult cardiologist your buddy. That's sure to reap good dividends. Okay. So mitral valve inflow Doppler, we learned where to put the sample gauge. Now the various waves. IVRT or what all we study, IVRT, EA ratio, and the D cell time. Remember that in patients with, for example, dilated cardiomyopathy and reduced ejection fraction, the mitral inflow Doppler abnormalities correlate better with functional class and prognosis compared to just looking at EF. You know all of the fallacies associated with EF. You could be stuck at an EF of 20% and in two different patients, one who's very sick and the other one who isn't that sick clinically, and the difference may lie in the diastolic parameters. So it makes sense to pay attention to the diastolic dysfunction when looking at DCMs. Going back to our waves, let me get to another slide then. The first bit before the E wave happens is the IVRT. Remember, here we are. This is the period isovolumic relaxation time beginning with the end of T wave on ECG, coinciding it with when the aortic valve closes. Rapid drop in the pressure with an equal volume because the mitral valve hasn't happened yet. So the IVRT has a normal cutoff, obviously, and if your relaxation is impacted, the IVRT will be impacted. If it's taking longer to relax, the IVRT increases. But if the left atrial pressure is high, and that's what happens in severe diastolic dysfunction, then the pressure gradient between the LV and the LA pressure increases, and hence the IVRT decreases because the mitral valve opens sooner. Why does the mitral valve open sooner? It opens sooner because the left atrial pressure is higher. It pushes the mitral valve open a little sooner. The adults have a nice distribution going on over here. For various age groups, they have cutoff. Pediatrics, it becomes complicated. Moving on to EA and E by A. In early diastolic dysfunction, when myocardial relaxation alone is affected, the peak E velocity decreases. Why? Because the driving force is the LA-LV pressure gradient. In early diastolic dysfunction, the LA pressure hasn't risen yet, while the LV pressure might be a bit higher. So your E peak comes down. When that happens, there's still a lot of the left atrium waiting to be emptied into the LV. So then compensatorily, the A velocity increases. So the E by A, where the A is the denominator, obviously becomes less than 0.8 or whatever the normal is. Here is an example. This is E, this is A. The ratio is 3.4, which is elevated, and this is seen in a situation where there's diastolic dysfunction where the left atrial pressure has risen significantly. Same thing here, in severe diastolic dysfunction, left atrial pressure rises and EA pressure becomes higher and higher. How do they change as diastolic dysfunction worsens? So this is normal. In early diastolic dysfunction, the E wave actually goes down, while in late, the EA ratio increases. Do we have normative data for mitral PWD for pediatric population? Yes, we do. We've got this reference coming from 2015. They looked at 233 healthy subjects, pediatrics, and they generated these various graphs where the dark blue is the mean, while the dark red is the +2 -2 limits. So you've got E velocity peak, you've got A velocity, you've got E and A ratio, so everything is displayed here according to what the BSA of the patient is. That was all about mitral valve Doppler. What about tissue Doppler imaging? So for this, again, we use the apical 4-chamber view. We optimize the depth. We make sure the sector is narrow so that we have more resolution. And we use the TDI setting in the machine. We place the sample gate at the annuli, but into the tissue, into the myocardium. And we make sure that the Doppler cursor is aligned to the movement of the tissue. Look at this. You know this is adult because it's got the heart inverted. So here A shows suboptimal DTI beam alignment. You've got your cursor here while the direction of annular motion is this way, so this is going to impact how your waves are. Versus in this optimal beam alignment, and you're looking at it live, you're looking to see how the tissue is moving. So the direction of annular movement is aligned to where the cursor is, and this what will give you a correct TDI tracing. So in TDI, we look at E prime, A prime, we look at IVRT, and we look at the E by E prime ratio also. Look at this. Here you've got a TDI of the lateral mitral annulus. It's showing E prime velocity, so that's reflected below the baseline. The first deflection seen here, right, after your T wave ends, and it's around 16 to 18, centimeter per second here, 19.2. So that's E prime right there. You can measure the A, and the S here reflects systolic function. So that's a whole different topic out there. And if your machine is tailored that way, you will get an E by E prime ratio if your mitral PWD is already taken lateral for the lateral annulus. You can do similar for the medial annulus. The medial annulus, also called the septal, is kept septum, so not towards the atrial septum, down near the ventricular. How high the E prime velocity will be, it's dependent on how your LV, when it contracts, is like a coiled spring. Coil bouncing back. So that's what's happening over here, and that's reflected. Also impacts it. The lengthening load. By that we mean how to velocity. So pretty consistently it reduces. It doesn't increase it as much. The relaxation suffers, that impacts the peak, and RCM impacts the peak. Sorry, can everyone hear me? Are there problems with the connection? Septal display versus the lateral. Remember, the lateral is always higher than the septal. That's because how much the myocardium moves. At the lateral, it moves more than it does at the septal. number one. Number two, when we come around to analyzing, what we actually do is we average out the two. There are actually two schools of thoughts, but the most current one is it's better to average out. And out of the E prime and the A prime, we concentrate on the E prime and we average out the septal and lateral and use it for analysis. You're saying, one is 6.7, the other is 10, so what should I use? Because your cutoff for showing something as normal is 8, let's say, for a particular age range, then you average the two and look at the, the mean number. For calculating out the E by E prime also, you average out the E prime and then get your final E by E prime ratio for the heart. The peak E velocity, like I mentioned before, consistently reduces as LV relaxation suffers and as LV compliance suffers. It's pretty faithful. It isn't like peak E wave, if you recall. The peak E wave in early diastolic dysfunction behaves differently compared to how it looks when there is severe diastolic dysfunction. It's like a faithful beast, peak E velocity. The E by E ratio also gets very high marks for helping us in understanding diastolic dysfunction. The E by E ratio directly correlates with the LV filling pressure. If it's less than 8, you can be reassured that there's normal filling pressure. If your E by E prime is more than 15, it predicts you've got elevated filling pressure. In between is a gray area. So like I said before, you have to average out the septal and lateral E prime velocities and then use that to generate the E by E prime. Less than 8 means normal LV filling pressure and more than 14 means high filling pressure. We do have normal data for TDI for pediatric population as well. The very same paper published in 2015 has generated E prime velocities and S and A and also E by E prime ratios. So if you look at someone with a BSA of 0.5, your E by E prime ratio, the top limit of normal is around 9. There are also tables available from other publications. This is from Talgeva's book, this table. And the data is actually items published in 2004. So this is a summary. We're running short of time. This is a summary of mitral PWD and tissue Doppler as diastolic function worsens. So this is normal. E velocity is less. And then as dysfunction increases, E velocity goes on increases. For the tissue Doppler, the E prime velocity comes down as diastolic dysfunction increases. Important to mention Dr. Liv Hatley whenever we talk about Doppler ultrasound. She was the one who started using it and coming to useful conclusions. She stays in Norway. Important tool that we don't utilize is tool number 3, which is left atrial volume. And it denotes chronic diastolic dysfunction. And there's a way to measure it. To get your apical 4-chamber view, you have to get into the lowest rib space possible. That creates this kind of view. So this will help decrease the foreshortening. You have to freeze the frame, freeze the loop, and right down to just before the mitral valve closes. That's just before the mitral valve just opens up. So when it's maximally filled up, the left atrium, that point take it and then go get your probe rotated 90 degrees so that you get a 2-chamber view at the apex and get your LA volume sorted out there. The machine will spit out a left atrial volume biplane. So when your LA size increases, it means there's diastolic dysfunction, but there are ifs to it. If there's mitral stenosis or mitral regurgitation, obviously the reason for left atrial enlargement is something different. Similarly for bradycardia, or if there's anemia, arrhythmias, you cannot use left atrial volume for studying diastolic dysfunction. But otherwise, it's a very helpful parameter. Also remember that in early diastolic dysfunction, LA volume will be normal. LA volume increases as your left atrial pressure increases. We do have normative data So this is from 2012. You can use these Z scores to see if your left atrial volume is normal or not. Quick revision, most important point is that you should know where to gate your data, where to obtain information from. If you mess up there, no use proceeding further. Use normative data. E prime is very good because it's faithful, and E prime is also very good. Do not forget LA volume. Also remember that diastole has two components. The first component is relaxation, LV relaxes, and second is the relaxed LV then distends as the atrium pushes blood into it. So that's compliance. Diastolic dysfunction affects relaxation first and then compliance. We'll skip this slide. Lot of things covered in the last 40 minutes. So if you're confused, you're not alone. Too many diagrams, too much physiology, too much variation, all that and more. Which is why the American and the European colleges of cardiology came together and published this in 2016. This document, and it's freely available, talks about diastolic dysfunction evaluation, and they've really simplified things, really simplified it. Before I take you through the two flowcharts that they have, remember some golden rules. Number one, thou shalt have a pretest probability in mind before venturing into mitral or tissue Doppler indices interpretation. What this means is that make sure you've listened to the patient's history, you've examined her, you've looked at your heart thoroughly, looked at your LVEF, looked at the mass, ruled out hypertrophy, ruled it in, and then you're evaluating diastolic dysfunction. You will not rely on a single value. You shall try and find if the LV filling pressure or the LA pressure is elevated. You shall follow rules to obtain good mitral, pulse Doppler and DTIs and optimize tracing. You shall stick the Z scores in your echo lab so you can refer to them, and in your reports you should compare the current value with what it was previously. Tabulate your data for serial evaluation. Most importantly, if you see a dragon, know that it is a dragon. Don't go about pulling out your smartphones and opening up Wikipedia to find out what a dragon looks like, how many claws it's supposed to have. What I mean is, when you have severe systolic dysfunction, for example, you're going to have diastolic dysfunction. If your indices aren't adding up and giving you a clear picture, there's a problem with your data, or there are things impacting how you're studying your diastolic dysfunction. Don't be confused by that slew of data that you get that doesn't fit in. Recognize that there's diastolic dysfunction. There's bound to be diastolic dysfunction when there's impacted ejection fraction. Don't turn your head away from diastology if your indices don't add up. Let it encourage you to understand it further. So let's look at the two flowcharts that JASE employed. So please, once this lecture is done, go back and look at these and stick them up in your echo lab. What they say is, first find out if your ejection fraction is normal or not. So if your ejection fraction is normal, look at these four things: E by E prime, and they have a value. The E prime by itself for the septum and the lateral. The third is the TR velocity, which remember means the PA pressure, whether there is pulmonary hypertension or not. And fourth is the left atrial volume. I'm not going to go look at the numbers and mention them right now because you won't remember them, I don't remember them. Easier to stick them up in the echo lab and refer to them when your next adult patient walks in, or refer to your pediatric charts when you have peds patients. So anyway, look at these four parameters: E by E prime alone, PA pressure estimation, and the LA volume. If out of these four you have more than 50% positive, you have diastolic dysfunction. End of discussion, perhaps. If you have only one which is positive, your diastolic function is normal. And in between, it's indeterminate. Simple. Another flow chart for when the EF is reduced. At that point, when you know your systolic function is reduced, you know there's diastolic dysfunction. It's going to happen. Question is how much? Is it early diastolic dysfunction or late? So that's when you first look at your E by A ratio, and if it is abnormal, which in adults means a ratio more than 2, directly you're looking at elevated left atrial pressure and grade 3 diastolic dysfunction. They've made it really simple. Secondly, if it's not so, at the other extreme, if it is less than 0.8, you have grade 1 dysfunction. In between, if your E by A is more than 0.8 but less than 0.2, then you have to look at other things. But the very same things we looked when the EF was normal, which is E by E prime, the TR velocity, which is the PA pressure, and the volume index of the left atrium, more than 34 ml per meter square. So if all three are abnormal, then you have grade 2 diastolic dysfunction with elevation of left atrial pressure. And if they are less than that, then you know there's diastolic dysfunction, but you really are not in a position to give an accurate estimation of left atrial pressure. So here they are saying, listen, you know, all this, whatever diastology we do, it has its limitations. So cannot determine means cannot determine until we are wiser. So that was that. It's just 3 minutes left to 9. And let's take a little quiz now. I'll put the chat box right up here so I can see your answers. First is you select the true sentence. There's only one true sentence. The first is E prime velocity measures LV compliance. This is E prime. Is that true or false? E velocity, the E, that is mitral blood velocity, E velocity, measures LV relaxation. Third, E by A is elevated in early diastolic dysfunction. Is this true? And E by E prime is a sensitive marker of diastolic dysfunction. There's only one true, all the others are false. So somebody says D and somebody else also. I'm pretty happy with that. Let me just quickly refresh it for everybody. So E velocity across the mitral valve reflects relaxation normally. E prime velocity, I'm sorry. So E prime velocity reflects relaxation normally, while the E reflects the compliance. The E by E prime is a very sensitive marker of diastolic dysfunction. It is abnormal in diastolic dysfunction. The E by A velocity, E by A, in early or mild diastolic dysfunction is actually not elevated, it is reduced. Question 2 is mitral PWD sample gate is to be kept where? A, B, C, D, E, F. So the answer somebody says is D, more people say D, and that's true. You want it to be neither too high, your velocities will come out skewed, and neither too low. Very, very vital. Where should you keep your lateral TDI sample gauge? Should you keep it at the annulus, the lateral annulus, at the hinge point, or a few millimeter into the myocardium from the hinge point of the lateral annulus of the mitral valve? So the answer is C, correct. You have to keep it on the myocardium. You have to move a little bit away from the hinge point and keep it on the myocardium to get a true tracing. Okay, which is the false sentence? If E by E prime is low, it means diastolic function could be normal. If E by E prime is low, diastolic function could be normal. Is that true? if E by A is low, it could be early diastolic dysfunction. And third is high abnormal E by A means high LAP. So out of these three, there's only one which is false. So somebody says C, or is that from the last question? I don't know. Let me go over this again. Somebody says A is false. So that's true. And E by E, which is less than 8, means diastolic function is normal. 8 is a good cutoff. Good cutoff, even in pediatrics. In general, if your E by E prime ratio is less than 8, means you're doing good as far as diastolic function. The ratio climbs up as diastolic dysfunction worsens. Sentence B, in early diastolic dysfunction, the E by A will be low. And sentence 3, high abnormal E by A means high LAP, absolutely correct. And high LAP means you're at the more severe end of diastolic dysfunction. Oh, I had another option to just skip over it. Okay. Question 5 is this flowchart we had seen. In patients with normal EF, you're looking at these 4 parameters, right? So how many parameters do you want out of these to be positive to call it as diastolic dysfunction? So, the answer is you want 2 or more than 50%. More than 50% of these should be abnormal. So you can look at these numbers for adults, and for pediatrics, try and use your charts. Then you are in diastolic dysfunction range. Okay, here's one, especially for me. Take 2 golden rules of diastology. So, certain things we have to keep in mind. I would give number 1 status to getting good tracing, taking time to keep the gait properly. And number 2, recognizing that there will be diastolic dysfunction if ejection fraction is impacted. Number 3, do not interpret single values. Always use combinations. Okay, so now we actually have no time. I'm going to skip pulmonary hypertension and M mode evaluation. I'm sorry, I don't do it. I did find literature about it, but seems to me there's enough data which says that it's not reliable. There are better ways, and I'm sure somebody will be covering pH evaluation in echocardiography for you. Aortic valve measurements, there is this 2010 publication from American Society talking about how to take aortic valve measurements. So just follow those, and you have the valve opened out over here in systole. When you measure hinge point to hinge point, that is where you're measuring the aortic annulus. Then you measure the intersinus distance here, the biggest measurement, aortic root, then the sinotubular junction and the ascending aorta. That's how we measure it. That I'm measuring on the ascending aorta there. The TAPSE, remember this is tricuspid annular plane systolic excursion. So what we need to do is, after we obtain our 4-chamber view, we actually switch in, we decrease the depth and we switch on color, and then we use the M mode cursor and keep it on that echogenic spot over there, which is the annulus of the tricuspid valve, and we look to see where the high point is and the low point. Now why we use color? I'm almost done. Is because it helps us differentiate where your annulus is peak is changing. So blue red, you see that over here. So right here is where I would take 1 point, and the second point would be right here, where again the blue red changes. So whether I measure it or somebody else measures it, they will always be measuring it at that point. So this is a tip given to me by my very helpful adult cardiology colleague next door. Simpson's biplane for the LV. you ask your adult cardiologist to guide you for the first some time. And here we are optimizing how the LV looks, and we'll go ahead and the machine pretty much guides you. It says, select the biggest diastolic, the most distended LV that you can get with the mitral valve closed, and just as it closes, that's when the LV volume will be the most. So it'll give out a tracing, and then you go ahead and you optimize it. Make sure you include the mitral papillary muscles within the cavity of the LV, and again scroll and get your smallest volume, and that's your systolic frame. So repeat everything, all the steps there. Then go ahead and get a 2-chamber view and repeat that, and it will give you a biplane ejection fraction. One very, very important number that it also gives out is the end diastolic volume by biplane. Please get in the habit of evaluating end diastolic volume. It is a much better marker of LV size compared to our LVIDD. So you can index it and compare to adult values. You can serially follow up with it. So the next time you have a VSD with LVVO, try looking at the Simpson biplane and the EDV that it generates. I have to pause here. I'm exceeding time, so thank you very much. Kavita, done?